Ringrazio innanzitutto Franco Dossena per aver prodotto un nuovo filmato visionario sul futuro della cardiologia, e grazie Franco per il lavoro che fai a sostegno di questi pomeriggi del Cardiocentro. Arriviamo al terzo anno, quindi abbiamo cominciato nel 22, è stato in fondo inizialmente quasi più una sperimentazione di temi, anche per capire se c'era interesse da parte del pubblico, dei medici, per temi che venivano proposti ad intervalli mensili. E si è visto che in fondo l'interesse c'è, è un interesse importante, con una partecipazione più che soddisfacente, quindi in media dalle 70 alle 120 partecipanti, persone, a dipendenza dei temi, un pubblico misto, un pubblico di voi in sala, un pubblico di voi a casa o in studio o in ospedale, quindi medici cardiologi, medici internisti, medici giovani medici, medici sul territorio. E quindi ogni anno, insieme al professor Auricchio, che aveva iniziato questo progetto e che da settembre ha iniziato una nuova attività non più al Cardiocentro, e anche con il professor Valgimidi ci siamo posti la domanda: cosa può interessare? Inizialmente abbiamo proposto temi quasi di pertinenza esclusiva dell'ambito cardiologico, e poi con il tempo abbiamo cercato di andare verso il territorio, anche verso i medici. E quest'anno è la prima edizione che organizziamo anche con diciamo così, la partecipazione dell'ordine dei medici, quindi sulla brochure vedete anche la firma del dottor Franco Denti, presidente dell'ordine dei medici, proprio perché ci si vuole avvicinare anche alla sensibilità del medico curante, che poi non è diversa dalla sensibilità del medico cardiologo. Quindi sono comunque temi che ci toccano e sui quali è importante poter disporre oggigiorno delle conoscenze nei confronti dei nostri pazienti, ma anche nei confronti dei colleghi. Quindi vedrete dalla brochure che è stata distribuita che abbiamo creato, concepito un 9, se non sbaglio, 10 temi, 5 in primavera, inverno, primavera, 5 in autunno, dedicati a diversi ambiti della cardiologia. Sul primo tema ritorniamo dopo, perché di questo ne parleranno soprattutto i moderatori e i relatori, però a febbraio si parlerà di stenosi aortica, quindi la stenosi aortica, patologia molto frequente che trattiamo adesso da ormai 15 anni di routine, patologia delle persone anziane, fino a dove ci si spingerà nel trattamento delle stenosi aortiche. Parleremo in marzo del MINOCA, quindi dell'infarto miocardico coronario normale, un'entità diventata molto importante anche per la possibilità diagnostiche intracoronariche. Parleremo di scompenso cardiaco in aprile, quindi la patologia per tutti i medici, di obesità in maggio, quindi con i fattori di rischio e con le nuove terapie estremamente efficaci, anche protettive nell'insufficienza cardiaca. Parleremo di grandi anziani in giugno, un tema estremamente importante perché tutta la medicina è confrontata con l'aging, e vi ricordo che il Ticino si è candidato per un progetto importantissimo, quello che si chiama NCCR sull'aging, che quindi come promotori insieme all'Università, al Politecnico di Zurigo, alle PFL di Losanna. Quindi l'aging è il futuro della ricerca, il futuro della medicina, e il grande anziano sono i pazienti che stiamo già trattando oggi. Poi le novità dal congresso di cardiologia in settembre, come ogni anno, gli anticoagulanti orali, la chiusura dell'auricola, tema ritornato in auge dopo le recenti pubblicazioni sulla fibrillazione atriale in ottobre, cuore e tiroide in novembre, quindi un tema in fondo importante perché lo vediamo in tutti i pazienti cardiologici e di medicina interna generale, e poi la prevenzione primaria. Quindi abbiamo cercato davvero di distribuire un ampio spettro. E la seconda novità è che i primi anni i chairman erano sempre, era il primariato, quindi Auricchio, io, Valgimilli, e quest'anno sono prevalentemente i nostri quadri, i nostri capiservizio, con degli esperti esterni o anche in certi casi con medici sul territorio. Quindi questa è l'idea di promuovere una discussione allargata con tutti. Vi ricordo che la struttura è quella che si è consolidata nel corso dell'ultimo anno, quindi 2 relatori e poi una presentazione di 1 o 2 casi clinici, con discussione sia durante, cioè fra le presentazioni o anche alla fine. E penso che l'importante è anche poter condurre una discussione dinamica, e quindi anche voi siete invitati sia dal Cardiocentro sia in maniera virtuale, siete invitati a partecipare alle discussioni, potete porre le domande e il nostro Franco Dossena farà in modo poi di mostrare le domande ai moderatori in modo che le possano rivolgere agli speaker. So I think I suggest that we switch to English, because this evening we have 2 speakers, one coming from Basel, the second one just online virtual presence from Barcelona. And I guess that English is we all agree that English is the official medical language, and I invite Professor Conte just to introduce the 2 speakers and then the chairman, and just lead the event. And thank you very much, Giulio, and thank you very much for everybody for joining us. Il Claudio ai relatori, non a... Forse un'ultima, ecco, l'ultima cosa, last but not least, che generalmente fanno alla fine, ma forse lo faccio da adesso, cioè evidentemente questi eventi non sarebbero possibili se non ci fosse il supporto costante e importante da parte dei nostri partner dell'industria farmaceutica e biomedica. Quindi ringrazio tutti gli sponsor che ritrovate sulla brochure che viene distribuita, dove avete anche la lista dei programmi, però vedete che è una lista abbondante, quindi riscuote successo, ma questo proprio perché vengono affrontati dei temi anche vicino a quelle che sono le nostre conoscenze in ambito biotecnologico e farmaceutico. Quindi un grande grazie a tutti gli sponsor per il vostro costante sostegno. Vi ricordo, ma lo dirà ancora Giulio, che alla fine ci sarà un aperitivo al primo piano del Cardiocentro. Mi fermo definitivamente.
Buon pomeriggio a tutti, è un grande piacere che vi do il benvenuto anch'io a questa nuova edizione di Pomeriggi del Cardiocentro, a questo primo incontro che, come vedete un po' dal titolo e anche dai relatori e moderatori presenti, ha un alto tasso di interdisciplinarità. Si parla di aritmie in gravidanza, quindi è vero, non sono presenti gli ostetrici, i ginecologi, il focus resta la cardiologia, ma è qui con me a moderare è presente una pediatra cardiologa, la dottoressa Amalia Stefani Glucksberg, con la quale abbiamo un'attività congiunta di valutazione di famiglie già da tempo con malattie rare all'Istituto Pediatrico di Bellinzona. Abbiamo il professor Stickerling, quindi un elettrofisiologo di spicco nel panorama svizzero e non solo. Abbiamo un'esperta di cardiomiopatie che è connessa online da remoto, la professoressa Elena Arvelo, e poi abbiamo un'esperta anche di cardiopatie congenite, la dottoressa Bonassini. Do la parola ad Amalia per introdurre il primo relatore.
Buongiorno a tutti. I have the pleasure to present Professor Christian Sticherling. He is Deputy Head of the Department of Cardiology at the University Hospital in Basel. He also had the Division of Cardiac Electrophysiology in Basel. And he also is the head of the research unit with a scientific focus in the risk stratification for the prevention of sudden cardiac death and clinical and interventional aspects of atrial fibrillation. Thank you so much.
Well, thank you very much for the kind introduction, Giovanni, Giulio. A real pleasure to come down here to Lugano. Usually I just told Giovanni I'm just coming down here to watch hockey games. I was really sorry to see what happened to your team over the last couple of weeks, but I'm glad to see right now they're back on the winning streak. So I've been given the task to talk about something that scares all electrophysiologists and all cardiologists for that matter when they're confronted with it. And if you work in a center like yourself here in Lugano, where you have a big obstetrics and gynecology unit, you inadvertently will sometimes be confronted with patients, pregnant patients, who do have arrhythmias, and that usually causes a lot of unease. And my task today is to keep the horses down a little bit. And I want to tell you that actually it's not too much different, and there's not too much harm you can do, because we're all afraid, of course, that there will be a harm to the fetus of the pregnant women, because treating the arrhythmia of the pregnant is usually not the problem, but our concern about the well-being of the baby. So what happens during pregnancy? What are the physiological changes? And I think some of these need to be repeated. You all learned it at medical school, but it's pretty massive, I must say. Usually, if we have somebody with increased LV wall thickness of more than 25% and an LV wall mass of more than 50%, it's a disease. It's hypertrophic cardiomyopathy or end-stage hypertensive heart disease. But this is something that the body of the pregnant has to put up with, because it's an adaptation to the increased volume load. And you see here that the cardiac output is increased by 20%. And the vascular resistance is going down, and the mean arterial pressure in the second trimenum also, it comes back almost to normal at the time of delivery. So quite a few changes. And in order to accommodate for that, of course, the hormonal status will change. And there are, oh, it's not forwarding, let's just see. Can you maybe forward? Oops, thank you. So that the plasma catecholamine levels rise, as does the overall sympathetic activity that can be measured. And at the same time, the parasympathetic tone is going down. And overall, you're in a state where you have increased sympathetic activity. And at the same time, due to the hormonal changes, you also have a more lax tissue overall. And that's why our interventional colleagues, when they are confronted with pregnant patients, then sometimes it's spontaneous coronary artery dissection, one of the most feared cardiovascular complications actually of pregnancy, because there you usually somehow try to open the vessel without it planning a stent. It can be very, very scary. But now for the talk today, I think it's important to know there's an increased sympathetic activity and the plasma catecholamine levels are increased. For some reason, I have problems with forwarding. Now, why is it important that we talk about it? And just to put everything into perspective, the number of pregnant ladies who are admitted to the hospital is increasing. Who are admitted during the pregnancy for any reason, be it preeclampsia or bleeding or spontaneous coronary artery dissection. Yet it is still very, very low. It's 0.05%. So it's not super likely that you will run into a catastrophe, but you would need to know what to do if that happens. And the number and the incident, the prevalence of the arrhythmias is also increasing. And the reason for that is numerous, manifold. One is that many of our patients with congenital heart disease who have been operated upon in the youth survive now to adulthood, and they get pregnant. And of course, we want them, if they have the wish to get a baby, to be able to sustain the pregnancy. Then the maternal age is increasing, particularly in Western Europe. And we have more patients with comorbidities who become pregnant nowadays. And you can see that also reflected in the fact that it's not only PSVT, supraventricular tachycardia, that is virtually stable, but particular atrial fibrillation is increasing. Still very, very, very low prevalence, but that is something that is noticeable and that can be complicated to treat. So let me just start with the case report of one of these ladies I've been treated. We are always cooperating with our gynecologist, with our pediatric cardiologist in Basel, Professor Birgit Donner, who is really a very, very good collaborator. And this lady is a 32-year-old female with her first pregnancy, and she noticed palpitations at the 15th week of gestation. And actually the reason why she came to the hospital is because she had a syncopal event. Now, if somebody has a syncopal event and is young and the heart is otherwise normal, common things are common. So the most likely reason for that is still vasovagal. And when we talked to her, she had really all the hallmarks of vasovagal syncope. Yet, because she was pregnant and she had very frequent PVCs, PVC burden of 18%, which she sort of noticed, but that didn't really bother her. She was now in our treadmill, so to speak, and we looked for what's going on. And in the history, she had myocarditis a couple of years before with a preserved ejection fraction and some subepicardial late enhancement of the lateral wall. So nothing really specific. And that was the ECG. Maybe, don't want to pick on anyone, but since I'm in the cardiology department, what do you think? Is that something worrisome that could potentially be related to the scar, or is it something that's more benign? And if we look, or if we think about idiopathic premature ventricular contractions, there are two big groups. Number one is the outflow tract, which is recognized by an inferior axis, which is not the case here. And the second one are the fascicular PVCs. And this is a rather typical example here because you have a superior axis, right, vital branch morphology, and RS that is changing at V3, V4. And this stemmed from the posterior fascicle. So that's a posterior fascicular, left posterior fascicular PVC, which is benign and it's idiopathic. And she was not hemodynamically comprised. But after we started this whole workup, of course, she was a little bit afraid. So what can you do? And I would recommend you, whenever anything is happening on the ventricular level, refer to the 2022 ESC guidelines on ventricular arrhythmias and sudden cardiac death. Tobias Reichlin from Bern and myself, we had the honor to be co-authors there. And there's this nice table which tells you which kind of drugs you can use for different PVCs. And this lady had like an 18% PVC burden. She now was a little bit at unease because she was in this whole diagnostic workup. And what you would do with the symptomatic patients, usually we would ablate them. But I will tell you why we are not too keen on doing that during pregnancy. But then these are the drugs that you can use for non-pregnant women. So class 2A for very common drugs, beta blockers, calcium channel blockers, flecainide. So we started her on metoprolol, and I can already tell you in pregnancy, for me, there are only two beta blockers. It's metoprolol. You could also use propranolol, but as you know, because of the short half-life, it's something we don't love to give so much. The pediatric cardiologists love it. But metoprolol is also okay. That didn't work on her, so caused severe fatigue, no reduction of PVC, and that would have actually been the better choice from the very beginning, would have been verapamil, reduction of PVC burden to 5%. She was pregnant, she was tired, but she was happy overall. So the fascicular PVC, they usually react very well to calcium channel blockers. And by far the most common is the left posterior fascicular that you just saw. So then she planned a new pregnancy, and therefore we decided not to run into troubles again, to ablate her. And we ablated her, 3 months later, her PVC burden was not down to 0. This is not very common that you see it coming down to 0, but was like 2%. And then she got pregnant again, had an increase of PVC to 5%, no interarrhythmic drugs and normal delivery with her second baby. So that's a fairly typical cause. And for you as a cardiologist, there's nothing special about it because you give drugs to her that you're working with every day. Now, what's the fuss about the drugs? It's not so much about side effects in the pregnant, but it's about what's happening to this little chap in here about the baby, because we are very scared about teratogenicity or other untoward effects that call hydrops fetalis or something like this. And there are some general principles. Now, the first thing to know is that whenever you learn something about the use of any pharmacological agent at medical school, nothing was considered safe in pregnant women because there are absolutely no randomized controlled trials. And we had this ABCD categorization, no fetal risk in controlled trial studies, we don't have that. And most of them fell into B or C. C was human risk cannot be ruled out, animal studies may or may not have shown risk. That's why we were all sort of careful to use it. Now, take-home message number 1 is the highest risk is in early pregnancy at the time of organogenesis, because that's when most bad things can happen to the fetus. The FDA rating is no longer be used. The FDA actually said this led to a situation where drugs were withheld without good evidence. We probably overestimated the risk for the baby. There are no randomized controlled trials in pregnancy. And here, unlike in heart failure therapy and other areas in cardiology, we want to use the lowest effective dose, only so much that we can control the symptoms of the patient. And I recommend you, if you're interested in that, to read this paper. That's a state-of-the-art review in JACC-EP, which is really excellent. And that gives you, on one slide, the drugs you can use and where there's extensive data. So there are no randomized controlled trials, but digoxin, in the pediatric world, they love it. Even if you want to treat an arrhythmia of the fetus, it is very, very often used. Lidocaine, for situations I will get to, and that's surprising, comes as a surprise to some people, sotalol is also safe. Of course, there are drugs that are really bad. Amiodarone is always bad, and it causes teratogenicity. Dronedarone we hardly use here. Dofetilide is only in the States, and evaporadate is also only in the States. But I think this is a pretty good selection of drugs to go with when you are confronted with a problem. In the very same paper, there's also a very good list of the evidence that we currently have. And you know, it's always difficult to keep everything in mind. So try to have your favorite drugs. And my 4 favorite drugs that I used already, it's not very common, but these are the ones I used, is for VT. We had a lady with congenital heart disease, we paired tetralogy of Fallot with VT, which we ultimately ablated. But we started with the acute symptoms with lidocaine. That is very, very effective. For PSVT, which is the most common presentation, I love to give either metoprolol or flecainide. And flecainide in this population hardly has any side effects, because here we are not talking coronary artery disease. But of course, you should be a little careful if we have operated patients, if we have congenital heart disease patients. And for atrial fibrillation, sotalol, which we don't give very often otherwise, has proven to be very effective and safe for that matter. Okay, so but what are we doing if they present with bradycardia? Even rarer than tachycardia. And that's a case of a 30-year-old woman that with her first pregnancy was referred to our hospital, and she was very early on in her pregnancy, so at the time where you ideally don't want to give drugs, if you can avoid it. And she presented with nausea and vertigo and also syncope. And if you look carefully at the first glance, the ECG looks relatively normal. But you can see here, it's not very good quality, but you can see here that there's actually a high degree AV block, and there are here very high degree AV block, and then there are periods of complete AV block. And she actually had on telemetry 10-second pauses. So now what? 8 weeks of gestation, not the best time. I know, I mean, here in Cardiocentro, you can implant pacemakers beautifully with very little fluoroscopy, but ideally, of course, you don't want to do that. But there was no way around it. And what I want to tell you there is that it's possible to do that completely without fluoroscopy. So we did that a couple of years, almost 10 years ago, I think. Yes, 10 years ago. In this lady, here you see a nicer ECG with a complete heart block. The P waves are running through. And what we did here is we used the Cardo system just to create a map here, superior vena cava, inferior vena cava, the right ventricle, and then we sort of customized a system where we could put this clamps on the pacemaker lead, and then we implanted a VDD pacemaker, so single lead with atrial sensing. And zero fluoroscopy, here you can see that we had also very nice sensing, and that turns out to be very easy and worked very well, and we had absolutely no fluoroscopy. Nowadays, you also have other opportunities. You can use intracardiac echo, ICE, which is also very helpful in this case, and not invasive and no fluoroscopy. Okay, but that's what we are dealing with usually when we are talking about arrhythmias in pregnant women. It's a narrow QRS complex tachycardia here at a rate of more than 200. And if you see this patient, you treat her like every other patient. So if she's hemodynamically unstable, you would need to cardiovert her. If she's stable, you start with adenosine. And with adenosine, there's no problem to the fetus. It is actually crossing the placenta. And it is also used to terminate arrhythmias of the fetus, if that happens. But this works well. Of course, you start with vagal maneuvers. And with vagal maneuvers, I do not mean pressing around on the carotid artery or drinking cold water. But what you do then is, or what I always do, and I always have it in my pocket, I use one of the little balloons, you know, when your kids have the children's parties, you always have to blow these balloons, and that almost bursts your lung, particularly the little long ones. And this gives an incredible intrathoracic pressure. And if you use that, have the patient lie down and put the head up, put the feet up. There was a Lancet publication a couple of years ago from the UK with a conversion rate of 70%. So I think that's very helpful. Now, if they repeat to have arrhythmias, you can give beta blockers or digoxin. Of course, always in the absence of pre-excitation. If it's a pre-excited ECG, then don't fuss around, just give flecainide, because that will treat it, that will terminate the tachycardia and will block the accessory pathway, and you don't have the risk of rapidly conducted atrial fibrillation. And if that becomes a problem, you can ablate it, and with our new ablation systems, it's really not a problem. You can do that without fluoroscopy. If you need to go to the left side because you have an accessory pathway on the left side, then you can use ICE to avoid fluoroscopy. So does that have an impact? So if somebody presents with paroxysmal supraventricular tachycardia, is that bad for the pregnant lady? Usually I would say no, but you can see here that it's an analysis from 8 hospitals, women, primiparous or multiparous without a cesarean section before and structurally normal hearts. And they were admitted in labor to one of 8 hospitals, so at the end of pregnancy. And of those, only 76.05% had at least one symptomatic documented episode of PSVT. And what the authors did, they did a 4-to-1 propensity score matching with 304 women without PSVT. And what you can see on the forest plot is that women with paroxysmal supraventricular tachycardia more often underwent cesarean section. I don't know whether this is because there was a medical need or because everybody was so excited about it and thought, you know, we rather don't take the risk, play it safe, and also in the States. But, and this is something that cannot be explained by the circumstances of the treating people, the preterm labor was 4 times as common. So there is something about it which is not so good. And the SVT recurrence of women with a history of supraventricular tachycardia was super high. So if you had a history, then you were much more likely to have another episode during pregnancy. And therefore, I think that's the second take-home message. If you have a patient who had a PSVT during pregnancy, it is wise to advise her to undergo radiofrequency ablation before the next pregnancy. Because it's either AV-NRT or AV-RT, success rate is in the realm of 98 to 99%. And it's very, very safe. Good. So this now becomes much more difficult. If you have a pregnant patient with atrial fibrillation, you need to consider, of course, whether you should put her into a normal sinus rhythm, which I would suggest. Most of them revert on their own. So it's most of the time paroxysmal, the vast majority. But you can also try to slow them down with beta blockers and digoxin or calcium channel blockers. If that occurs often and the patient has no structural heart disease, is not a grown up with congenital heart disease patient, then I would put her on flecainide until delivery. But you do have to perform a TTE, because I showed you in the beginning, you have a 20% increase in intravascular volume. You have a pretty big dilatation of the left ventricle, and sometimes pregnancy also uncovers an underlying cardiac disease. And you don't want to miss now severe mitral regurgitation or something like this. You need to rule out thyroid disease. And then the big question always is, should you start her own anticoagulation? Because that becomes difficult. And here it's different from the non-pregnant in that DOACs, apixaban, rivaroxaban, edoxaban, and Pradaxa, they're all forbidden in pregnancy. This doesn't start and so on. But this is just an example for ablation, because you can ablate them. That's how an intracardiac echo looks like. I told you the biggest problem for intracardiac during a left-sided ablation is the transeptal puncture. If you use eyes, you have a very good visualization. You don't, thank you. You can see here the needles popping through the fossa ovalis. It's actually even better, I think, than with TE. And then also just an example, that's not in the pregnant, of course, but you can then use the CARDO system and can create a map in no time. So you create a map. Usually, of course, in a pregnant, you don't have pre-procedural imaging, but with this catheter, it's very easy and very quick to create a map to give you an idea about the anatomy and then ablate the 4 veins. I say you that now. I'll know that because you're working in a ablation center. Okay, so but how do we approach now the whole anticoagulation issue? And here it becomes complicated, and then the hematologist should also be involved probably. So the American 2023 guidelines and the ESC 2018 guidelines both recommend that in pregnant women with atrial fibrillation and additional risk factors that place them at high risk for thromboembolism, anticoagulation is recommended as a non-pregnant women. That means you need to evaluate their CHA2DS2-VAS score. You all know that the female sex does not play a role anymore since last year. And then if you have to put her on medication, then you should use the same regimen that is used for patients with mechanical heart valves. And to my big surprise, because we never did that, people who are specialized in these pregnancies, in high-risk pregnancies in patients with mechanical heart valves, they do use low-dose warfarin, and the risk for something bad happening to the fetus at a low dose seems to be okay, but at high doses, it's reported miscarriage rates up to 30%. So what we would usually do is we would go for a low molecular weight heparin, and there you need to measure then the anti-factor 10A activity, or unfractionated heparin, which is of course not a very good idea for 38 or 39 weeks. And then closely before delivery, you need to stop both and put her on unfractionated heparin until 6 hours before delivery. So heparin and low molecular weight heparin both do not cross the placenta, so the fetus is not at harm, but DOACs do, and they are contraindicated. So I think that is probably the most complicated situation if that occurs in arrhythmias in pregnant. And then, of course, that's something that we had the other day. That was is ECG of a patient actually shortly after she delivered. She had preeclampsia with her second pregnancy. That was after her fourth pregnancy, and she had syncopes. And when she showed up, you could see this arrhythmia, a lot of PVCs, and then it was up to point tachycardia, which terminated on its own. So we are still at the workup with her. I suspect that she has long QT syndrome, so we implanted her with a defibrillator because she also had numerous episodes of fainting, and her mother, she was from Ukraine, died 4 years ago in Kiev from sudden cardiac death. But if you have a hemodynamically unstable tachycardia, do everything like you always do it. So you can do the same CPR protocol. The first line therapy for drugs is lidocaine, and the second line is procainamide and quinidine. Quinidine in particular in patients with other structural heart disease. And ablation can be considered if it needs be. We have never done that. We never had the need to do it. And of course, for polymorphic VT like this, you can acutely also give IV magnesium. That brings me to the worst possible situation, cardiac arrest in a pregnant. I've only encountered that once in a lady who presented with spontaneous coronary artery dissection, so it was a completely different situation. But that's a very rare, extremely rare event, 1 in 12,000 hospitalizations. And the CPR should be performed as in everybody else. The only thing you need to be aware of is that when they are in their second trimenum, you should tilt them a little bit to the left side, because if they lie flat, supine on their back, you will have an autocaval compression. So that's something to bear in mind, which apparently does make a difference. And no drug should be withheld because of concerns with fetal teratogenicity. That's, I think, clear. And in this situation, if lidocaine wouldn't work, you would also give IV amiodarone. And defibrillation or electrical cardioversion, as I said before, carries no risk for the fetus. Yeah, so in summary, it's something everybody feels uneasy with when you are asked as a cardiologist what should be done, but I hope I could show you that it's pretty easy. It's almost always like we always do things. Use 4 drugs, lidocaine for VT, sotalol for AF, and metoprolol or flecainide for paroxysmal supraventricular tachycardia. Then I think that's also important that somebody had a problem and had been admitted to the hospital during the pregnancy because of PSVT. I think we should try to persuade them that they should undergo ablation of this arrhythmia before their next pregnancy. I told you about the favorite 4, and ablation can safely be performed during pregnancy without X-ray exposure, as can pacemaker implantations. And with that, I thank you for your attention, and yeah, I'm open for questions. Thank you very much.
Thank you for the presentation. It's very, very interesting and nice. Are there questions from the audience? Also?
Thank you, Christian. Very nice talk and a very comprehensive overview. Maybe two quick questions. One about the
Maybe you should ask me on the
Okay. Präkanide during the Gravidanza, Schwangerschaft.
Yes.
So if you have any way to stop in the first or last trimester, I don't remember. And the other question is you show the prevalence of arrhythmia, which are increasing over the years. But I mean, in my experience, probably also yours, finally, we don't see very often women with atrial fibrillation, for example. And if I think how many persons come to our attention because of atrial fibrillation, so I was wondering there. I mean, pregnancy is a nice, actually, possible trigger for arrhythmia. So there have to be some protective mechanisms against atrial fibrillation. What do you think about this?
Yes, I think, I mean, the first point is super important, and I tried to make that point in the first slide. It is very, very rare. 0.015% of all women hospitalized for labor. So it's a very rare event. Now with flecainide, actually that's a one drug that you can probably give all, I mean, you should give all the drugs as long as possible. And the obstetricians then do ultrasounds, because some of them do cause hydrops fetalis, it's called, you know, this accumulation of fluid that they can see in ultrasound that resolves when you stop these drugs. So if that does not happen, you can give flecainide until the end of the pregnancy and beyond. There's one, the beta blocker, the obstetricians want to stop a week before because they don't want to have bradycardia during delivery. There's one exception, and the one exceptions are women with a known long QT syndrome 2, because they have a very high risk of arrhythmias after the pregnancy. The first 9 weeks after the pregnancy is the highest risk situation for them. So there, it's recommended to administer the beta blocker also beyond delivery. And the second question was whether there are any protective mechanisms. You know, for me, it's a wonder when I see how little changes outside of pregnancy cause severe symptoms. You know, I mean, heart failure, with preserved ejection fraction, where you can hardly see anything on echo, and people are so symptomatic. And here you have 20% more blood. The LV mass doubles. It's amazing, and I have, of course, no explanation for that. It's a wonder of nature.
Another question? Yeah, I have one. I'm a pediatric cardiologist, but this possibility in the increase, the association between the increase in the arrhythmias in the pregnant women and the new risk factors, obesity, old age, and other. Is there a possibility to do a prediction about these risk factors and the possibility to have the arrhythmia?
I doubt that. I mean, it's all observational data. It's retrospective observational data from the United States that just shows that it's going up. And the explanations are increased age. The age is the one risk factor that we can clearly identify. But all the others, the incidence is so low that you can, it will be impossible to build a model where we can predict it.
I have also a question. First, thank you for the great talk. Also, the nice examples of arrhythmias. You showed a worrisome escalation of different types of arrhythmias that we wouldn't like to face with during our clinical practice. My question is again on atrial fibrillation. We have seen, as you showed, temporal changes in the atrial fibrillation, let's say, epidemiology during pregnancy. So now it's almost as frequent as VT compared to the past because of the increased maternal age. So my question is, do you think that atrial fibrillation is still a rare event during pregnancy? Because we treat atrial fibrillation by ablation at the early stage. So you said once you get atrial fibrillation at the first pregnancy, you should be treated. But probably this is rare because we treat before the first pregnancy. What do you think about that?
Yeah, but I mean, here I was referring to patients who had their first episode of atrial fibrillation during pregnancy. And if that happens because of all, I mean, not because of the antiarrhythmic drugs, but because of the anticoagulation, which I'm concerned of, because that is really cumbersome during pregnancy, I would then recommend to undergo an ablation. Because in this population with structurally normal hearts, our success rates are so high now, and the intervention duration is, we are down to 35 to 40 minutes skin to skin, that I think we should offer that, yes.
And the other question, do you discuss family planning with your patient at your heart rhythm clinic? When you face with a young female with an arrhythmia, do you ask about family planning in order to be prepared about some problems in pregnancy?
Yes, so if you have like the typical 20-year-old with AV-NRT who comes to the emergency department, then we usually recommend her to have it ablated because it's a 1A indication if you have been hospitalized for it. Because then you were so symptomatic that brought you to the hospital. And then one of the arguments that we can use to convince her is that it will probably make her family planning much easier. And you could also see that for some reason there was a lot of preterm labor, which is hard to explain by our reaction to that. I mean, these women had earlier labor.
Thank you very much, Christian. A beautiful though really nice. Just a question concerning anticoagulation and atrial fibrillation. Just to decide whether anticoagulate or not, you just rely on the CHA2DS2-VASc score. You don't have all the tools helping you in the decision in pregnant women.
No. So your recommendations?
Because I think from the hematological point of view, from the urological point of view, it's not the same as in normal women or men, just that the pregnancy just changes some coagulation factors. I have no idea concerning the risk of stroke.
But that's true. It's a pro-thrombotic state, and the risk of stroke and pulmonary embolism is higher during pregnancy.
And the stroke rate
is not higher.
Not high.
Yeah, I mean, there's no data on patients with atrial fibrillation because it's so low. But you know, if she is an otherwise healthy 35-year-old, I would probably not give anything. But if she has hypertension or any structural heart disease is not really reflected in the guidelines, then I would...
Just the CHA2DS2-VASc as in the rest of the population.
Yeah, but I think when she has a CHA2DS2-VASc of 1, I would rather lean towards oral anticoagulation. Usually you don't.
We have a very last question from a colleague. I don't know who is because it's anonymous, and he's at home. We have quite a lot of colleagues at home that are following this session. So the question is about labetalol first. What about labetalol? And the second one is DOAC seems not safe during pregnancy. Do we need a randomized control trial? Would this be ethical to be performed or not?
Yes.
And the very last question is on the third point, who do you suggest ECG screening in all pregnant women or at least in high-risk females?
No, I mean, high-risk females, those are grown up with congenital heart disease or with heart failure, they are followed by cardiologists anyway. But there, yes, I think screening is important, but they will become symptomatic. It's very unlikely that they will not be symptomatic. Labetalol is not such a good idea because it's an alpha and beta blocker. And as I showed you during pregnancy, your peripheral and your pulmonary vascular resistance is already low, and they tend to be hypotensive, and we have other options. So propranolol or metoprolol are perfect. in patients with long QT syndrome who are on chronic beta blocker and who are on Nadolol. I know, can you get that here from Italy or?
And we have it. We have,
Oh, you have it?
Yeah.
Because I always send my patients to France to buy it. That should be continued. And the third question, yes, of course, randomized controlled trials are great, but there's not a single randomized controlled medical trial with medication in the field of cardiology in pregnant ladies.
Thank you, Christian.
Thank you.
For the great discussion. Thank you. Now it's my great pleasure introducing Professor Elena Velo. Elena is a great old friend. We first met back 2008 in Barcelona when I was a fellow. Elena Velo is leading the clinic on cardiomyopathies and sudden cardiac death syndromes at Hospital Clinic of Barcelona. And Professor Velo is also the chair of the last guidelines, ESC guidelines on management of cardiomyopathies, and is also the first name. So Elena, it's your turn.
Thank you very much for the invitation, and I apologize for not being there. It was quite complicated with the program to travel there back and forth in the day. So I'm very happy to be here. We've been friends for many years. We're not old, Julio. We're only know each other for long. And I think the topic's quite interesting. Unfortunately, probably as in the previous case, a lot of the information that we're going to discuss is not based on large studies, but I hope I can clarify some aspects of management of cardiomyopathies, of pregnancy in cardiomyopathies. These are my disclosures. To start with, I would like to explain what a cardiomyopathy is considered according to the guidelines. Basically, it's any myocardial disorder that cannot be explained by another cause, or at least that other cause is not sufficient to explain the degree of muscle disorder, either functional or structural. That can be coronary artery disease, congenital heart disease, hypertension, or valvular disease. So, are you seeing the slides properly? I'm not sure. Hopefully you are.
Yeah, we're it.
Okay.
Yeah.
So the last cardiomyopathy guidelines, what we did is actually change from naming cardiomyopathies in a classification to saying that there are 5 different cardiomyopathy phenotypes, but these phenotypes needs to be further evaluated with a multiparametric approach, so that you go beyond saying the heart is thick, the heart is dilated, and that you phenotype better. So you evaluate whether each of any of these cardiomyopathies has arrhythmias, if it has a genetic background, etc. I'm going to focus, give some general data, but the data that we have regarding pregnancies in cardiomyopathies are mainly in hypertrophic, dilated, non-dilated left ventricular cardiomyopathy and arrhythmogenic. There's very little information on right restricted cardiomyopathy, so very little data in general for this type of cardiomyopathy. So one thing that I would like to highlight is that cardiomyopathies or genetic inherited cardiomyopathies are in general rare, except hypertrophic cardiomyopathy. But the truth is that there are other alterations or cardiomyopathies that are considered to be external or triggered by an environmental factor, and this includes peripartum cardiomyopathy that may also have a genetic background. So this is what they call the second hit theory, where you basically have a genetic predisposition, and then you have a pregnancy or myocarditis or another disease that leads you to develop the muscle disease. I won't go into detail because this has already been explained by the previous speaker, but there are many changes happening in pregnancy regarding volume, heart rate, etc., and also in metabolism. So this is going to influence also the management and treatment of our cardiomyopathies, and this we need to take into account. And in fact, when we evaluate different cardiomyopathies, we see that depending on the degree of cardiomyopathy, the risk of a pregnancy may be negligent or negligible, or it may have a very poor prognosis, and therefore pregnancy should be contraindicated. We need, as in previous cases, we always need to pay attention to different aspects. First is whether the woman with a cardiomyopathy will have a risk of progression of the disease or decompensation during pregnancy. We have to take into account the possibility of transmitting the disease to the fetus. When planning pregnancy, we also need to take into account the concept, have a birth plan or the mode of delivery, and we must remember that pregnancy does not finish at delivery. We have what we are not, people are starting to call the fourth trimester, which is basically the few weeks after delivery, where the woman's body needs to go back to normal, and there you may also have some type of decompensation or problems. I took this image from a graphical abstract in rhythm, and it was referring not to cardiomyopathies, but to inherited arrhythmias. But I think it's a very nice summary of what we need to take into account when we're facing a woman that's considering getting pregnant. We need to evaluate pre-pregnancy different aspects. We need to optimize medication, consider the medications that we may not be able to administer when the woman gets pregnant. We have to consider the disease and the disease state, because there are some stages where the adverse outcomes are so high that we may need to advise not to get pregnant. And then we need to take into consideration the genetic aspects, or because most of these cardiomyopathies have, especially those that present at childbearing age, have a genetic background. During pregnancy, we have to monitor the disease, we have to take control of the treatment, and we have to review the ICD and manage the ICD for delivery in those that are carrying this device. You need to plan and have a proper birth plan, both for the emergency situation and also for a planned delivery. And of course, as we say, in the postpartum, you need to monitor the state of the woman and reintroduce that medication that you may have needed to stop during pregnancy. The other thing is that you need to consider that the newborn needs to also be assessed by an expert team. And this needs to be managed before pregnancy, during pregnancy, and at delivery, by a multidisciplinary team. The guidelines, the 2010 guidelines, already suggest that you need a cardiobstetric or a pregnancy heart team, whatever you want to call it. That of course needs to include the maternal fetal medicine, but you need to have experts in cardiovascular medicine. You need to have the anesthesiology prepared for the time of the delivery. You have to coordinate the different groups, and of course, in specific situations, you may need to call in other colleagues. And regarding cardiomyopathies, let me take out my face, because I'm seeing my face and I do not see the slide. Sorry. Okay, there. And regarding pregnancy, you see that I'm pretty sure that you're all know this classification, the modified WHO's risk or prediction of risk of cardiovascular risk in pregnancy, and how it classifies the different diseases by 4 stages or 5 stages. Cardiomyopathies, as you can see, are all classified in the higher levels. There's no cardiomyopathy in the low level classification with low risk, but you may have those in an intermediate area that's called the WHO 2-3, when you don't have or have only mild left ventricular impairment, or you might have hypertrophic cardiomyopathy. If the degree of left ventricular impairment is moderate, the people are considered to be in class 3, and that means that you have up to 1/3 of women that have complications during pregnancy, and in class 4, where pregnancy should be discouraged, are those that have severe left ventricular dysfunction, or are in NIA class 3-4, or they have had previous peripartum cardiomyopathy. I will add here severe left ventricular obstruction in hypertrophic cardiomyopathy, which is not included in this classification. We have another tool, the CARPREC score. This was initially a first study in less pregnancies, and then they had the second study, which included almost 2,000 pregnancies, and they evaluated different aspects of the patient history, physical exam, specific lesions, imaging, etc., to try to predict better who would have complications from pregnancy. And this is overall, this is not just patients with cardiomyopathy. And when you look, they came up with these 10 predictors with different ways, and they were able to better predict who would have events. So here you have the predicted, the actual numbers from the derivation cohort and the validation cohort. And when you have very little, so no points or just 1 point, you have a proportion of events that's very low, and this is consistently higher the more points that you get. And this is interesting because when you look at this compared to the WHO, the modified WHO class, you have people that are high risk even in the lower or intermediate classes from this classification. So this is something that we can make use of, the modified WHO plus the CARPREC score, to try to predict which of our women are at high risk of cardiovascular events during pregnancy. So this needs to be done before pregnancy. Obviously, when you come pregnant, there's no discussion, or you may have discussion of interruption of pregnancy. But before getting pregnant, when a woman comes to us saying, hey, I would like to consider having a child, we have to discuss the risk based on these classifications and other markers, and this is mandatory in women with cardiomyopathies. The minimum checklist that we need is an ECG, an echocardiogram, and a Holter based on the guidelines, but it's highly recommended that we consider stress tests, especially in situations where you have a borderline left ventricular ejection fraction, where you have a mild left ventricular obstruction in hypertrophic cardiomyopathy, because stress test is an attempt to simulate this overload that the woman will experience when she gets pregnant. The other thing that you want to consider is the natriuretic ties to evaluate the possibility or the status regarding heart failure of the woman. So that's regarding the woman. Now we have to think the other aspect, the genetic nature of cardiomyopathies. You know that most forms of cardiomyopathies have an autosomal dominant with genetic heterogeneity, incomplete penetrance, and variable expressivity. But we have also some intermediate effect variants, or the added effect of common variants. In any case, there's a genetic background, and we need to consider this possibility when considering pregnancy. The genetic yield, so the proportion of women, or in general people, that where we identify a pathogenic variant in the different cardiomyopathy phenotypes, is around 40 to 60%. And when we take this into account, we need to give genetic counseling. This genetic counseling needs to be done by an appropriately trained healthcare professional in the multidisciplinary team. So it needs to take into account the cardiological aspects. It needs to take into account the genetic aspects and the risk for transmitting this to the descendants. And it has to take also into account how the different genetic variants may have a different prognosis. When we do genetic testing, or prenatal genetic testing, ideally is we identify a variant, and then the woman gets the option of deciding whether she wants to opt for an in vitro fertilization to choose or get pregnant with a descendant that won't have that pathogenic variant. When the woman comes to us with that variant, with the pregnancy, then there are very different options. But it's important to know that this is something available, because this is allowing the couple to decide whether they want to continue or not with the pregnancy, and at the same time tailor also the follow-up of the pregnancy and early days of the baby when it's born. I'm not going to go into detail how that happens, but basically for in vitro fertilization, they fertilize, and then when you have an 8 to 10 cell blastoma, they take 1 or 2 cells to do the genetic testing and choose those that don't have the genetic variant. Another aspect for pre-pregnancy evaluation and counseling, the medications. You know that a lot, if not most, of the drugs that are used in heart failure are contraindicated. Also, it has been mentioned before, some of the antiarrhythmics that these patients may take. So, and this is something that we have to pay attention, because as soon as the woman is pregnant, they need to be stopped. Regarding the birth plan, I'm not going to go into detail, but from the European Cardiomyopathy Registry and the pregnancy registry, we see that elective C-section provides no benefits in women with cardiomyopathies, and this is important. So most women with cardiomyopathy should undergo vaginal delivery and consider only C-sections, either for obstetric indications, women with severe left ventricular outflow tract obstruction, or if they are in a difficult to treat heart failure. So when we go into detail for the different cardiomyopathies, I'm going to explain some cases. This is a 36-year-old female that comes to the clinic considering getting pregnant. She has a history of obstructive hypertrophic cardiomyopathy, which was diagnosed in family screening after her brother died suddenly at 22. She's in NIA class 2. She has palpitations and a slightly elevated proBNP, and she has an MIH7 variant. At 23, she presents with palpitations. In the Holter, you see an unsustained VT. She had significant severe left ventricular obstruction. So she had an ICD implanted to prevent sudden cardiac death, and it was treated for the obstruction under beta blocker and verapamil. She was still symptomatic, so she underwent a septal myectomy. So that's her history. This was preoperatively on the left, postoperatively on the right. She improved the NIA class, and the obstruction was solved. So when we look at the European Registry of Pregnancy, when we look at the women with hypertrophic cardiomyopathy, these were in total 60 women. 41 of them had a obstruction, and 23% had at least one event. The events were distributed throughout the pregnancy, but were mainly related to atrial fibrillation or the presence of heart failure or ventricular arrhythmia. Ventricular arrhythmias mostly presented in the second half of the pregnancy. And when you look at what were the factors that predicted the occurrence of the events, they were basically the same that we were talking about for CARPREG, and what you would consider in women with hypertrophic cardiomyopathy. So those women that had signs of heart failure and advanced NIA class, and if they had elevated right systolic pressures during pregnancy. And this is another paper of the few papers that have been published that summarizes the literature up until now. So the incidence of maternal death is 185 in 100,000 pregnancies. 1% had ventricular tachycardia, 4% atrial fibrillation. And as you can see, there are other complications like eclampsia, heart failure, etc. So how do we handle this? Hypertrophic cardiomyopathy is classified, as I said, between class 2, 3, and 4. And if you have severe left ventricular obstruction and or left ventricular dysfunction, this should be considered a high-risk pregnancy and probably consider interrupting, especially in class 4, because the rate of events is almost 100, between 40 to 100%. So this woman with the septal myectomy, no residual obstruction, she had 2 pregnancies without any problem. There's a second case. This is different. This is a 31-year-old female. She had been diagnosed through family screening, another MIH7 variant, but she did have symptoms, heart failure symptoms. She was in class 2. not a brilliant, it was okay, but not a brilliant 6-minute walk test, and non-sustained VTs on the holder. Elevated pro-BNP. And in the imaging, what we saw, it was a hypertrophic cardiomyopathy that was it was concentric, also affected the apex. And although she had a normal left ventricular ejection fraction, she had a longitudinal dysfunction in the strain. She had diastolic dysfunction and dilated, very dilated left atrium with elevated pulmonary artery pressure. She had a high risk of sudden cardiac death, and then the ICD was implanted. So if we look at the same registry, we see that in this type of cohort, there was a 20, or in the whole hypertrophic cardiomyopathy cohort, there was a 25% risk of MACE, and this was more evident in those that were above class 1, and that the event rate, when you classified it without so no left ventricular dysfunction, no obstruction, the event rate was between 10 to 20%. And so it was recommended, people traditionally recommend at least a bi-monthly follow-up. However, if you look at the CARD-PREG, the score was 5, and the risk was much higher, it was 41%. And in here, I mean, what really counted was the presence of arrhythmias and pulmonary hypertension. So what happened with the woman? She presented, you don't plan sometimes if you get pregnant. So even though she was advised that to attempt pregnancy with caution, she showed up 13 weeks pregnant. And so it was a single a single pregnancy. She had elevated BNP, and she was still dyspneic, but the imaging parameters were similar. However, along the pregnancy, so this was September, in October and November, fatigue, palpitations, dyspnea progressed, the pro-BNP levels increased. She even had paroxysmal atrial fibrillation. In between, she had COVID, which was even worse. And then she started developing heart failure, right heart failure symptoms like lymphedema. So she was started on diuretics. In January, so that was at 28 weeks, she had spontaneous premature delivery. She had a puerperal infection, and she had heart failure decompensation, class 3-4 with elevated parameters. This is the imaging. Although the left ventricular ejection fraction seemed normal, there were parameters, increased LV filling pressures, right ventricular systolic, longitudinal dysfunction, elevated pulmonary artery pressure, which clearly showed a decompensation that had started during pregnancy and complicated during delivery. So she was treated, and she progressively ameliorated. So in hypertrophic cardiomyopathy, you should re-stratify basically the same as in non-pregnant women. You should continue beta blockers in those women that were taking them, and consider giving them in case or whenever women develop a outflow tract obstruction. These guidelines are old. We can discuss later cardiac myosin inhibitors, but up until now, at least mavacamten seems to be potentially teratogenic, so it's contraindicated during pregnancy. And based on the registry, C-section should only be considered in those patients with severe left ventricular outflow tract obstruction or severe heart failure. Regarding dilated cardiomyopathy, there's very few publications regarding severe dilated cardiomyopathy with severe LV dysfunction, because pregnancy has traditionally been discouraged. And as you can see in the very small studies that are reported in this review, with very few pregnancies, events occur. So isolated cases, mainly of atrial fibrillation or some VTs, sudden cardiac death. You have heart failure, and there are other complications, abortion, death, etc. So the main recommendations in DCM and non-dilated LVC, especially if they have dysfunction, is that as we mentioned before, you modify the therapy before pregnancy. Those that are contraindicated are summarized here: ACE inhibitors, ARBs, MRAs, sacubitril, valsartan, and SGLT2 cannot be given during pregnancy. Beta blockers should be considered and ideally switched to beta-1 selective ones. And you have to monitor throughout the pregnancy the LV function with echo and pro-BNP. One specific and very short comment on peripartum cardiomyopathy. The cause is unclear. There's a genetic predisposition that's added with other risk factors like multiparity, twin or pregnancy, the presence of smoking, etc. But this genetic predisposition can be present in up to 20% or around 20% of patients, mainly cardiomyopathy-related gene variants in truncating TTN or filament C, BAC3 or DSP. It has a high not a significant rate of mortality if untreated, and the diagnosis is of exclusion. So you have to rule out other causes for cardiomyopathy. How you diagnose it and manage it is you have to detect natriuretic peptides, ECG, chest X-ray, and echo. If there's severe deterioration, you have to transfer to a center with experience of managing acute heart failure in women. You may even need temporary mechanical circulatory support, but if you have stabilized heart failure, you just use heart failure treatments. Although you have to avoid those that I mentioned up until delivery. It's a situation with a very high thromboembolic risk, either arterial or venous, and therefore prophylactic anticoagulation is indicated. And bromocriptine, there's very few studies, but and small studies, but they suggest that given bromocriptine at least for 1 week together with anticoagulation may increase the chance of recovering the left ventricular ejection fraction. It's important to consider that there's a high risk for arrhythmias, and the wearable cardioverter defibrillator should be considered until recovery. I will short case because laminopathy is a case where pregnant women are of concern. This is a familiar case of non-dilated left ventricular cardiomyopathy. You see an ECG with prolonged PR Holter. Sorry?
No, go.
Okay. Holter with non-sustained beating and a high count of PVCs. She had borderline ejection fraction, non-dilated, and on the CMR she had late gadolinium enhancement, especially in the basal segments. And she wanted to get pregnant. So she was offered she had a preconceptional consultation. She was offered about the possibility of preconception and genetic diagnosis, which she went for. She was treated with metoprolol, and she had a bradycardia, near syncope, and ICD implantation. But with that dose, 4 months later, she was pregnant. So the patient was followed every 3-4 weeks, and also the baby, to see that the fetal growth was okay. During pregnancy, she had increased feeling of palpitations and fatigue, and there were frequent PVCs and increasing non-sustained VTs, up to 20 complexes and runs of paroxysmal atrial fibrillation. Importantly, the ejection fraction seemed to decrease a little bit. So she was induced because of progressive symptoms at week 34. During delivery, she had 2 runs of non-sustained fast BT, but there were no complications. And she was okay, and the ejection fraction returned to normal in the follow-up. She was advised not to have further pregnancies. Lamin AC or laminopathies are a specific type of non-dilated or dilated left ventricular cardiomyopathy. And as you can see, if you look at the years, this is a general laminopathy registry. The childbearing years, it usually is a fairly stable period for the woman, but now that women we are having babies later and later, we're entering this later stage of life where we may have decompensations, and the high volumes and the overload of pregnancy may lead to deterioration of the disease. However, there's only one study in lamin A mutation carriers, and when they looked and they compared these 89 women, 60 of them that had at least one pregnancy, the outcomes seemed not to be different. So there didn't seem there was a higher likelihood of arrhythmias because or due to the pregnancy. Three slides, final slides of arrhythmogenic cardiomyopathy. There's even less information. There's this small study with 26 women. When you look at this is the previous history, if there was no history of ventricular arrhythmias and no major right ventricular abnormalities, still some women developed symptoms or ventricular arrhythmias. With history of ventricular arrhythmias, this didn't have. And then there were even some isolated cases of heart failure, especially in those that had major structural right ventricular abnormalities. So in overall, it was a 30% of these 26 women that had ventricular arrhythmias and 5% of heart failure. There was a particular concern that pregnancy would increase the risk of ventricular arrhythmias. There's this small study with 77 ARVC women, and the number of pregnancies did not really seem to influence the phenotype of arrhythmogenic cardiomyopathy. So arrhythmia-free survival was irrespective of the number of pregnancies. And then a later study with a larger cohort of almost 200 women had similar findings. When we look at these two studies, this first one had 5 women that were mutation carriers with no phenotype. And when they looked before and after pregnancies, there were no the markers of disease structural progression, and these similar findings comparing those women without pregnancy with women that had had at least one pregnancy, there were not significant differences in the imaging measurements, suggesting that pregnancy may not influence the progression of the disease. In general, recommendations, pregnancy is well tolerated and you should continue the beta blocker. So with this, I'll finish. Most women with inherited cardiomyopathy do well in pregnancy, but you have to avoid pregnancy or consider interruption when you have severe left ventricular dysfunction or severe symptoms, NIA class 3-4, previous peripartum cardiomyopathy with any residual impairment, and I'll add severe left ventricular obstruction. What you need to do is what we mentioned, pre-pregnancy counseling, pregnancy heart team, and there you have to evaluate the risk, optimize medication, have a birth plan, and then remember always that you have to monitor after the pregnancy, both adjust maternal medical treatment and see her clinically, and also refer the newborn for care and testing if needed. So thank you. And I'll stop sharing.
Thank you, Elena, for this great overview. You showed a really great contemporary and modern approach to cardiomyopathies, even in pregnant. So is there any question? We don't have time to lots of questions. So I have just a very quick question. At your institution, do you have any pregnancy team who is involved in the team? So it's suggested for us.
So what we have, the key people that we always have on the team is the obstetrician. So we have a pregnancy heart team, so that we would have the arrhythmia expert, or that also includes channelopathies expert. Then we have the cardiomyopathy expert. We have an expert in the lead of the valvular clinic, but she would only come if there are patients with that, the same way that the congenital heart disease expert would come on a call basis. Then we have an imaging expert, because a lot of these women with cardiomyopathies, it's easier to have a quick look at the echo parameters with the imaging. So that's cardiology and that's obstetrics. We have the anesthesiologist, always the people that are going to devise the plan and also the type of medication that is going to be given in the delivery. And since for the past 2 years, I mean, we had them, but they didn't show up really. But it's become more important to have the neonatal cardiologist also present, because sometimes we forget about that the woman has a baby inside and that these conditions are potentially heritable. And they may need to be treated during pregnancy or right after delivery. So we had a case, this is not a cardiomyopathy case, we had a case with long QT where the baby was exposed to beta blockers because of the mother was taking the beta blocker. And when he was born, nobody thought that, I mean, they looked at the baby, he was healthy, nobody thought of doing the ECG up until 24 hours later. Nothing happened, but he had an extremely severely prolonged QT that might have even been seen during pregnancy. Probably not. We did very detailed echoes, but when he was born, he had beta blocker withdrawal, and it was it was a particularly risky situation. So we now have neonatal cardiologists coming every meeting to our heart team.
Very similar case with a fatal to sudden one. That's why we started also our joint consultation, but unfortunately we don't have still a real dedicated pregnancy team, but maybe we can discuss for the future. So
Yes.
thank you again, Elena. And if there are no other questions, I would like to invite Dr. Bonassin. She's a specialist and expert in congenital heart disease, and she will share with us a special case.
So, hello everybody, dear colleagues, the audience, thank you for the very kind invitation to bring a clinical case. It's not exactly a case, it's a life history. And as a cardiologist in the field of atrial congenital heart disease, I frequently follow risk pregnancies, and risk pregnancies are frequently burdened by arrhythmias. So I decided to bring a case. It might be a bit complex from a point of view of the anatomy, but this case summarizes a lot of aspects that are important during pregnancy, and there is a very important aspect in this case. This patient is Ticinese. So I think a few of the audience already met the patient. She was born with a very complex anatomy, a univentricular heart, double inlet, transposed raised arteries, a parachute mitral valve, and obviously she was operated on very, very early, and within the first year of age had a pulmonary spending and later on a Fontan palliation to create a univentricular physiology that would last for decades. And you can see she had a very unusual technique, and it's important for congenital heart disease specialists to know the surgical technique, as we will attend or expect different complications. And this technique is very peculiar, as you create a lot of scarring in the area of the surgery. So this is the result at the moment. She has total cavo-pulmonary connection, so vena cava inferior and superior directly into the pulmonary arteries, and the single ventricle pump only into the systemic circulation. This patient, we know Fontan patient might have a lot of complication in due course. However, this patient had a very uneventful 4 decades of life. She was asymptomatic, no evidence of heart failure, good saturation. She has been exercising, walking around with a big dog, was working full time, had medication consisting on aspirin and Labril, and had a very stable relation. So at the age of 37, she just said, life looks so good, it might be good to have a baby. And at this point, I'm happy we touched this topic already before. It's absolutely essential that all patients that have underlying cardiac disease of any type, congenital or acquired, that they undergo pre-pregnancy counseling. And it's very important, if they don't want to get pregnant, that you also discuss contraception. It's really, really an essential point. And we do need to assess their risk and the risk for a baby. So she underwent a very thorough workup in CHUV in Lausanne, where she was followed up. She had a transthoracic echocardiography, showed a good systolic function of the single ventricle. She had an exercise test, 140 watt. It's a good, satisfying exercise. She was stopped, so intraoperative was stopped in advance, just to make sure she would tolerate it well. She had normal NT-proBNPs, did not have history of arrhythmias, and was checked with Holter ECGs, and had further very complex investigation. She had a heart cut that didn't show any anatomical issues with her fontan circulation, but increased fontan pressures. It means something like increased filling pressure. It's a bit of a sign of deteriorating circulation, but we couldn't do anything about it. And as these patients have increased risk of having congestive hepatic disease, she had a transjugular liver biopsy that showed no cirrhosis, but fibrosis. This was a cardiac magnetic resonance. You see, it's a very complete investigation, and it's right to be done so. And you can see, especially in the transversal view, that the contractility of the single ventricle is good. So the case was brought by a colleague from CHUV at our inter-university ACHD meeting. Basel, Interspital, and team from USZ were there, and we had a very thorough discussion about this case. It was not a debate, it was brainstorming. And Elena already mentioned the modified WHO classification. It's a very important tool to understand the risk that our patient will undergo starting a pregnancy. And definitely fontan patients are in the absolutely highest risk category. You can see fontan patient with no complication and high risk categories, class 3, and fontan patient with any kind of complication should be advised against any pregnancy. And when you do this, you really need to stick to objective facts. You can go by your gut feeling. It's important to stick to objective things, and findings of the complete investigation didn't show any complications in these patients. So we had to state that she was in class 3 and she should undergo a very complete information about this, but we didn't see any contraindication. As she was living in Lugano and she is a bit far away for a pregnancy, she was referred to my clinic and I saw her in Ticino in January 23. This was my echo. You can see a good systolic function of her single ventricle. It's a very peculiar echocardiography, a moderate AV valve. Clinically, no issues, but resting ECG was already a bit strange. There was some definitely junctional rhythm that at some time switched to a sinus rhythm, and this is typical in this kind of surgery with a lateral fontan tunnel. So at this time, I decided to exercise her, and ECG address was showing again a normal sinus rhythm. By exercise at 100 watts, she was still in sinus rhythm. And just for comparison, this is again 100 watt ECG, but you can see that at rest, something probably changed at some time. I was having the impression that the ECG was already looking a bit more different, but for sure, when she was at 5 minutes of rest, her atrial activity was completely looking differently. And I was sure she was having a re-entry tachycardia. In any other patient, you would say it's a normal atrial tachycardia, but this is different. Those patients have a lot of scarring, have a diseased heart, so you should consider them as having flutter-like arrhythmia, and the next step was to discuss if she should have anticoagulation. And as we discussed before, actually there is no evidence on congenital heart disease. We cannot use really the CHA2DS2-VASc score, and as this episode lasted for several minutes, I felt she was completely fulfilling criteria for starting anticoagulation with Kumar. And actually, discussing all the findings of my consultation with her, I really made clear that she was swifting towards a class 4, and I told very openly my concern with regard to a pregnancy. And especially this patient would expect a very high rate of arrhythmias during pregnancy and high risk of strokes. So the next call I got was from the Cardiocentro a few months later. She was admitted to hospital with an arrhythmia. She had a syncope. She was running to the bus and had a sudden syncope, was found and transferred by ambulance. And at the Cardiocentro, the ECG showing these very peculiar flutter waves that are not classical flutter, but are a re-entry around the area of the surgery, was shown. She was conducting 2 to 1, and very probably, as this kind of arrhythmia is lower than usually, she probably had a conduction 1 to 1, which is explaining why she had a syncope, and obviously being compromised and not feeling well, she underwent immediately electrical cardioversion. She was discharged the day after and was pre-pregnancy optimization of her circulation was discussed, and obviously we arranged for her to have an EP study. And this was very difficult. You can imagine you don't have access to the intracardiac chamber, so the tunnel needed to be punctured to get to this re-entry arrhythmia, and there was the need for doing a very extensive ablation of this big atrium. Finally, she recovered not badly, her BNP went down, and we discussed again risk. But the next call was for saying that she was pregnant, as very frequent, and it shows how patients understand risk very differently from doctors. So we had a lot of things to do. And first of all, the anticoagulation. So she was on Marcuma, and this is an issue during pregnancy. Christian was mentioning this. Yes, warfarin, Marcuma syndrome, vitamin K antagonists are teratogenic. They might cause this very typical dysmorphia and calcification of the bones and also fetal loss. And there are different ways to approach this problem. She was taking a high dose of Marcuma, and she didn't have any mechanical valve or rheumatic disease, so the way was to switch her to low molecular weight heparin with very tight control of antifactor 10A, and actually in twice-a-day dose, which is the best way to do it. And you can imagine it's very annoying to inject for during 9 months. So she started a journey into the pregnancy, and I saw her very frequently, 7 weeks in Cardiocentro. I saw her then in Zurich at 10 weeks. She had a first episode of re-entry tachyarrhythmia at 11 weeks, but it was self-limiting. And then she was started on aspirin by my colleague of the obstetric team, and she was at risk for preeclampsia. You know, aspirin has a very good effect on risk reduction for preeclampsia, and with this regard, you don't need to stress because this is really an obstetric indication. So this is not something that needs to be decided by the cardiologist. Obviously, she had further problems. She came back again, this time with again a re-entry tachyarrhythmia, a bit different, with different conduction, still tolerated really poorly. And now the question was, what should we do now? And yeah, I think it was really good. Christian was telling you do what you would do normally. And what we do in this situation is generally only one thing, but let's try to go through the option just for explanation purpose. And obviously, I would be worried to give beta blockers in this situation or amiodarone. First of all, because she was already bradycardic, and this is not a very tachycardic episode. And second, you want to have success very quickly. And second of all, obviously, as mentioned before, you in very, very rare situation, you could consider giving amiodarone. However, this is really off-label and it might cause goiter and a lot of problems in the baby. So not an option. And the question was, let's go for electrocardioversion with transesophageal or not. Obviously, she was anticoagulated, so no need for T. And then a quick mentioning of the risk of transesophageal and echocardiography in pregnancy, which is a very risky procedure. The pregnant women are generally at risk of having aspiration and should be considered as full stomach from the second trimester. So she was cardioverted successfully with the backup of the cardio anesthesia. And at this point, there is a very important thing. Arrhythmia is a part of the problem. These patients have been operated on, they had intervention, and we have a lot of patients that do not have any access, peripheral, or access for installing, for example, catheter. And in this case, we already told before, there is no way to get intracardiac for a pacing. You couldn't pace intracardiacally if you should have any bradyarrhythmia. So preparation of any procedure in patients that are pregnant is quite essential. And as mentioned before, anticoagulation is really a pain during pregnancy. You start really you might have problems. So obviously she developed also atrial thrombocytopenia. It's a very frequent condition in pregnant patients, but it didn't make things easier. And she had a placenta hematoma, so we needed to stop aspirin and continue just Fragmin, but in a lower doses. She called again back. She was eating. Apple Watch showed arrhythmia, so I sent her again back to Cardiocentro, and she was switching from her arrhythmia, re-entry arrhythmia, and a normal sinus rhythm. We finally decided to take her over to Zurich. This was 18th pregnancy week, and I knew at this time, this was at the end of November, I wouldn't send her back again until she would, having a baby or having another outcome. And the reasons are very different. So we saw before the diagram of the physiological change, hemodynamic changes during pregnancy. So we are at the 18th pregnancy week, and the worst is still due to come around the 30th week of pregnancy due to the increasing cardiac output, increasing plasma volume, and the delivery is a very difficult time. And then additionally, this baby is now 300 grams. And at 18 pregnancy weeks, you cannot do anything about it. And you can start to think about the baby first from the 24 weeks. So it might be the only single pregnancy this lady will have. For that reason, we decided to take her in hospital and continue their care. We had, again, a brainstorming with our team of specialists, together with an anesthetist, obstetric team, neonatologist, and made a plan for any occasion. So we switched, obviously, the low molecular weight heparin to heparin, as it would be easier to handle in case of complication. We inserted a PICC line to be very flexible with picking blood and having anti-factor 10A checks. We took her on telemetry, and these columns are the days, and you can see she had every day several spikes of arrhythmias, but very luckily by now she always converted spontaneously. And the only measure I took was to increase metoprolol, which we heard is really safe during pregnancy. And by now she remained with very normal anti-proBNP levels. We need to check the baby. This woman has now reached 28 weeks, which is an achievement. And at the moment, we reached the very magic level of 24 weeks. We started to think about the baby. For that reason, we gave dexamethasone as a lung ventilation treatment, just to be ready for any occasion. And you can see this is the head of the baby, and this is her placenta, and this is a very unusual finding. So the fact that she had probably a very small placenta detachment and hematoma is causing sluggish blood to run through this enormous lacuna in the placenta. It's very unusual. And you can imagine that if this should detach completely, she really might die because of bleeding. And finally, from a cardiac and electrophysiological point of view, it was impressive. Since in November, we saw an impressive amount of very different arrhythmias with very different morphologies, different heart rate, different tolerances. But I said she really tolerated well by now. She had also some episodes of VTs, but I'm not that worried because this is not the kind of patient that will have sudden cardiac death, and she has metoprolol, so we take it easy. And finally, she also had a bit more of bradyarrhythmias since I've increased the metoprolol. However, we have her and the baby on monitoring. And as I say, she has daily CTGs, which is very important. To summarize, we are now by 28, 29. It's amazing. Our plan is to proceed in a very pragmatic way. If she would have an hemodynamic relevant or sustained ERTs, we would consider now amiodarone, as she is in a dangerous situation with regard to intubation. We would go for electric cardiovation. If untreatable, we would go for C-section and make a redo EP postpartum. And the question is if it's all right, so is it all good? And I think it's always depending on the perspective you look things. But it's for sure there is one very important take-home message is if you have a woman with underlying cardiac disease, and if you estimate them to have increased mortality, morbidity, they really should be extensively counseled before and during pregnancy. And ideally, we should try a way to concentrate their care. So thank you very much.
Thank you so much, Francesca, for this great, challenging case. So we're looking also forward to be updated about the outcome. So it's and congratulations for the management. Probably questions.
I think I can make a comment. I have to thank because it was great to have the backup and the support of all the colleagues here in Cardiocentro, and it shows the importance to have an outpatient clinic for congenital heart disease even here, as we are doing now, with your support.
Sure. I didn't mention that Dr. Bonassini is visiting our center constantly, at least once a month. So she's supporting and giving a great support to our patients from Ticino. I think from our patients this is of a great value. So thank you, Francesca, for the help. Giorgio?
Una domanda un po', una domanda leggera dopo questo caso incredibile. No, volevo, I just wanted to ask you, what do you do with these young females with congenital heart disease or advanced heart failure or whatever, who, though comprehensive counseling are not really, compliant, or you don't have you don't get the feel that the patient will follow your suggestion. Finally,
it's really very frequent. So the problem is we obviously we counsel every patient, and sometimes the one that really can get pregnant, they are the worst. The one that are the worst. They have the worst worries, and actually the one that are more critically ill, they really tend to to underestimate the risk, and the problem is they do not understand what does it means to get troubles during pregnancy. There is a chain of complications, especially if you start to have bleeding, if you need to have investigation, if you need to have a more aggressive treatment. What does it mean? And this is difficult. It's very difficult, and it's very intensive to counsel a woman with high risk constellation with regards to pregnancy. At the end, we will just help them. They will decide. We cannot oblige them. They need to have the information. The partner should be there. This is very important. And yeah, and we will help them.
I have a question. First, I thank you because we collaborated with them when our patient grew up with you, and that is grateful because have the group in which put our patients is very, very a good collaboration. And in this patient, do you think that the conversion to the total channel would be a good idea to prevent or to reduce the possibility of these arrhythmias?
So we generally, so overall, there are very little conversion surgeries by today in Switzerland, and I doubt there are still very skilled surgeons that can do this very challenging operation. And actually, she has already a total cardiopulmonary kind of treatment. It might be discussed. It's difficult to be said. Yeah, I think the problem today, we would rather push electrophysiology ways to the maximum to treat this patient, and only later eventually discuss other ways. But yes, covering in the area of the operation is a big problem. What do you think?
I agree. I think there's no reason. I think there's no reason for conversion surgery for arrhythmia treatment. It's only if it would be hemodynamically relevant, but I can't, not really. I mean, she has total frontal physiology right now. I think the scar is there. Used to be very difficult to treat all the mast patients, for instance, in early days with a bathroom that we needed to puncture, but we are so much better now. I showed the eyes and our systems are better. I think we would, as you said, rather go for another couple of operations because you can get there now.
And I even thought when at the time she wasn't reaching the 24, I even thought of considering redo EP, but she really had a very difficult access. I didn't mention she had dissection of both femoral arteries, and almost during the procedure it was difficult to find venous access, and yeah, so this would be also the last option during pregnancy, and now we are in a situation we can take the baby out.
So thank you, Francesca. Thank you all the speakers. I think this was a great start of the new edition. So we had really outstanding presentations. Thank you, Christian. Thank you, Elena. And thank you, Francesca, really outstanding. Grazie agli spettatori e grazie a numerosi anche colleghi da casa. Abbiamo raggiunto più di 70 colleghi collegati da remoto. Vi ringrazio tutti. Adesso andiamo sull'aperitivo per chi ha il piacere di fermarsi. E ringrazio anche Barbara Pedrazzi per l'organizzazione e il supporto. Grazie Barbara.